Today's webinar presenter is Dr. Jacob Strand. Dr. Strand currently serves as the Director for the Center for Palliative Medicine and as the Medical Director of the Symptom Management, Pain, and Quality of Life Clinic for the Mayo Clinic in Rochester, Minnesota. He is also serving as Assistant Professor of Medicine at the Mayo Clinic College of Medicine and also as the Associate Editor for the British Medical Journal Supportive and Palliative Care. Dr. Strand also served as a panelist for the Advanced Care Planning, Palliative Care, and Hospice Medically Led session at the PHA on the Road program this past June in St. Paul, Minnesota, and it is a pleasure to be working with him again tonight. So without further ado, Jacob, I'll hand it over to you.
We are going to move through a variety of things today to talk about a number of objectives. And really what I want to make sure we get at today is a good overview of what we mean when we say palliative care or supportive care. And I think that the terms are often used interchangeably. They're also used interchangeably with other terms that may not relate as well. And we'll talk about some common definitions and a good language that we can use and why it actually makes a big difference for physicians, nurses, social workers, chaplains, patients, their caregivers, and all those involved in the care of a patient with a serious illness like pulmonary hypertension. We're going to talk about some common myths and misunderstandings, in particular about palliative care, because I think people hear more and more about palliative care both in the news but also from clinicians and in hospital settings. And I think it's important to know what we mean and what we don't mean. We're also going to highlight some of information regarding the benefits of palliative care for a variety of constituents, and most importantly, our patients and family members, but also I'll talk a little bit about the benefits to the healthcare team as well. So we'll move on to the next section here and talk a little bit about a specific example of why it's important to go all through this together, particularly around the definitions and what it means for patients and their families. So I'll see if I can get my mouse to work here. There we go. So I want to tell you about a patient that I've been taking care of now, both in the inpatient setting and the outpatient setting for a while, and have changed his name and some of the identifying information, and also talked with him about this ahead of time. But Joe is a gentleman with familial pulmonary hypertension who's been in and out of the hospital now for a number of years. He watched his sister go through a lung transplant a couple of years ago and has been in conversations with his team about whether or not he would be a candidate for lung transplantation. But while he's been waiting for those conversations, he's had a number of issues that have come up. Most particularly, he's dealt with really significant pain and shortness of breath, as well as difficulty sleeping, and in a sense that his quality of life has been worsening over these past many months. I met Joe because his physician who was taking care of him in the outpatient clinic setting and I actually worked together on some other projects, and so she gave me a call and asked me to see him really to address those issues about pain management, difficulty sleeping, and his mood. When we first sat down in the office, it was pretty clear he had no idea why he was visiting with me or where he was, and certainly within the healthcare field, we don't often make things clear to patients with our labeling or locations. At the Mayo Clinic in Rochester, our clinic is actually housed within the pain clinic, and so he wasn't sure if he was seeing a pain physician or someone else. When we first started talking about palliative care, he got a little bit apprehensive because his first comment to me was, well, I'm not ready for hospice. And I led with that I thought that was great because I was not there to talk about hospice at all. And so we sat down and talked about the things that were really important to him. We spent that next about 45 minutes going over a variety of symptoms, including talking a great deal about his mood, what he was thinking about as he was going to visits with other healthcare professionals. And it became pretty clear that there was more than just anxiety about potential upcoming worsening of his health, but he was really dealing with a loss of his identity. He had been a pretty active guy, had been working a variety of different jobs before his illness got much worse. And so the loss of his quality of life was also a loss of his ability to see himself as an independent and productive member of society. And we spent a lot of time talking about ways to cope with that, both things that I could provide in our relationship together, but also things that I thought would be helpful to see another member of our team who really focuses on a lot of cognitive behavioral and mindfulness practices to help folks who are going through changes such as him. When we left that visit, he remarked that he thought it was kind of funny because I never once asked him about his end-of-life care, and I thought that was a good place for us to start because really the point of our visit wasn't to talk about his end-of-life care, it was talk about his life right now because that's what he was dealing with. And so with that, I want to kind of talk through a bit more about what that meant for him and some of the lessons that we learned together. I think it's important to talk about about what patients have said they want when they're faced with a life-threatening or serious illness. And throughout this conversation tonight, I'm going to use life-threatening, serious, or complex illness pretty interchangeably. And so I'll limit it to that as we're having this conversation. And there's been a number of studies about patients with a life-threatening illness being interviewed both in hospital settings and the clinic and thinking through what they want as they face that illness. And many things are pretty consistent across a lot of studies. I've cited one here, but this has been consistent across a number of studies of patients and their loved ones. And that when they think about a serious illness, they're worried about suffering. And one of the things they're worried about is making sure they have someone who's able to address their pain management, their shortness of breath, their difficulty sleeping, constipation, and other symptoms that might come up during the course of that serious illness. The other thing they're really worried about is their family or their caregivers, however they define family. They're worried about being a burden on them and sometimes even make decisions about future care as it relates to this concern about being a burden. But the other thing that's really critical is they want to have decisions with their medical care teams, in particular the people they trust most. So I've heard this from patients frequently, and Joe was one of those examples, that it gets really hard getting brought into the hospital frequently and then having to answer the same questions over and over again with people who don't actually know their situation, particularly as it relates to things like resuscitation preferences or CPR, breathing tubes. Those can be really traumatic conversations, and patients want to have conversations with the people that have been taking care of them for a long time. What they often get, and this is a failure on our end as a healthcare system, is they often get untreated or undertreated pain or shortness of breath. We see patients with a serious illness who have ongoing significant physical function decline. And I want to focus on this for a second, because when we think about pain and other symptoms, we're asking patients a lot in lots of places within the inpatient and outpatient setting, give us a number from 0 to 10 about how your pain is. But we're not asking them questions about their function. What can you do? What can't you do with your illness? How much does your shortness of breath limit your ability to play with your kids? One of the most pertinent examples of this was a patient I took care of with severe emphysema and really bad shortness of breath. And you know what? When he was sitting down, he was actually okay, and nobody asked him follow-up questions because he would answer, no, I'm not having any shortness of breath right now. But it was a huge burden to him that he couldn't get on the floor and play with his grandkids and their new puppy, and that's what was causing much of his distress, was that ability to be functional within his life. The other thing that we see are patients with a serious illness are often facing very high rates of depression and anxiety. And sometimes what we do as clinicians, and even patients and caregivers, having experienced this within my own family, is we say, you know, I'd be depressed too if I was going through that. But unfortunately, those aren't actually normal reactions. It's very normal to be grieving the loss of independence, but it's not normal to be clinically depressed. And so one of the things that we have to do better as a team is figure out how do we make sure we address psychosocial conditions for patients and the suffering they have that aren't necessarily related to a physical change in their body. The other thing they get are caregivers who are burdened. We see that patients, family members who see a patient who dies in the hospital or who is going through a really serious illness have much higher rates of depression and anxiety themselves. The other thing we often see is that patients often have inaccurate understandings of their prognosis and then make difficult conversations about what they want for their life. It's really hard to have conversations about end-of-life care, but it's even more so if we don't understand where we are in that journey along life's spectrum. One of the things I wanted to bring up was a piece that was written by Atul Gawande called Being Mortal. It's a really fascinating book looking at patients as they're facing serious illnesses and some of the things, again, we get wrong as a medical system. And one of the quotes that in that book that I thought was really powerful related to a conversation that he was having with his family after, I believe, his son's piano teacher was diagnosed with an incurable cancer. And what he wrote was, what is it we think should happen now? Her condition was incurable by established means. Should she press on with other treatments, anything with even a remote chance of keeping her alive, no matter what, or should she give up? And neither one seemed right. I think this is a really powerful quote because it gets at the problem that we have when we have conversations that are limited about in these two black or white conversations. Language is critically important because the goal for all of us is to improve the care for patients with a serious illness. We also know that many patients who benefit from palliative care or supportive care teams aren't dying and may be cured. I have many patients in my practice that I see in the outpatient setting and in the hospital who are going through, for example, bone marrow transplantations, heart or lung transplants, and they may do very well after a really tough period of time. And those patients are often willing to trade a great deal of upfront risk and even difficulty in their quality of life for the long-term goal of a cure. The other thing that's tricky is that when we talk about this good death and bad death, that's tough language, and I often struggle with that with my patients in those conversations, because most of my patients don't want to die. Most of us overall don't want to die, and few of us are able to be at peace with this type of label until we get to the very end of our life. And so it's not about a good death or bad death, but it's more about how do we live well for however long that might be with our serious illness. The other reason why I think language matters is that we tell stories to patients by what we say, but also by what we don't say or don't elaborate on. So I've seen conversations with physicians and patients talking about aggressive treatment or comfort care. And the problem with that language is that it insinuates that somehow keeping someone comfortable isn't about being aggressive. And I think some of this is about splitting a few hairs, but I can tell you I do a lot of very aggressive care to manage patients' symptoms, particularly their pain, their shortness of breath, their nausea, sometimes using radiation or surgeries or very potent medications to keep them comfortable. So aggressive care doesn't necessarily mean curative care. It just means care that we're doing very aggressively to relieve a certain problem. One thing that I heard a patient once here in a big meeting of team members was that one of the physicians talked about how this patient had failed therapy. And we went on with our conversation, and I came back to visit with that patient and her family about an hour later, and she was almost inconsolable. She was crying, feeling like she had let down her medical team because somehow she had done something to cause the failure of the treatment. Now, of course, this wasn't what the physician meant. She meant that really the cancer didn't respond to the chemotherapy that was being given. But you see, what we often say, patients hear a very different message. And so I think it's critical for us to understand the importance of language and how we use it in these conversations. I often have seen conversations that ask patients, well, do you want us to do everything? And my response as a palliative care clinician is to ask the follow-up question, which is, what do you mean by everything? Because I have patients who have very different definitions about what they want done or what they want not done, and it often changes during the course of their illness. When we think about the flip side of that is that there's nothing more we can do. This is one of the most obnoxious phrases that I ever hear in the hospital. Unfortunately, I'm not hearing it much anymore, but it still happens from time to time because that's absolutely not true in any setting. There's always something we can do as a medical team and as a patient and caregiver team to care for patients and their family members. Even if it's something we can't cure, that doesn't mean we ever stop caring, but these phrases often connote very different things to patients and families at very difficult times in their lives. The other thing that I see often is, again, this concept of making palliative care out to be something that it's not. And that's why I keep harping this idea of language. So I had a colleague of mine who I've known for a long time now say, you know, I actually don't think he's ready for palliative care. And I asked a couple of follow-up questions about why he was making these statements, and really it got to the concept that he was really worried that this patient wasn't going to do well, but didn't want the patient to think that he was abandoning him. And that's tough because I really tried to have the conversation back that palliative care isn't about abandonment. It's about surrounding a patient with an extra layer of support. And it's really gets to the idea of who's not ready and why. So I want to spend the next few minutes talking about some of the myths about palliative care, what it is and what it isn't, so that we understand and we don't get scared off by sometimes when physicians or other care team members are asking us to be involved in these conversations, because sometimes they're worried, sometimes the patients are worried, and sometimes it's because we don't have a good sense about the words we're using. So this is sometimes when I hear that question that I worry people are thinking, that we're coming on from a palliative care perspective as the death squad. And this is, again, something I think is less common. It certainly was more common when I started training, but it's something we need to think about. So when we think about those myths, what kind of myths do people see? So I see a number of them, and I kind of wanted to boil them down into a few. The first one is that palliative care is only for patients dying of cancer. Now, this one I can understand where people are coming from because, frankly, palliative care grew out of the hospice movement. and it was often used for patients who were dying of advanced cancer. Many early palliative care specialists were actually oncologists, physicians who took care of cancer patients. But actually what we see across the country is that while a large amount of palliative care is being provided to patients with advanced cancer, that's not the whole story. And in fact, many patients who benefit from palliative care will not have a diagnosis of cancer. The other thing is this idea that palliative care, just like hospice. I have people ask this question all the time. And I think it's important to understand that, again, while palliative care grew out of the hospice movement, palliative care is much more encompassing. In fact, as I mentioned earlier, many patients who are pursuing palliative care might be cured from either a transplant or some sort of therapy directed at their illness. And it's not that they're dying or that they're at the end of life, but they're having very difficult symptoms as they go through treatment for their serious illness. We also see that some patients are worried, and I think some physicians, frankly, are worried that introducing palliative care means that the care team is giving up hope. And again, this gets this idea that palliative care is only about end of life. And so I think it's important as we go forward to really focus on the idea that palliative care is not about end of life, but about living well with a serious illness. Another myth that we see frequently is that palliative care is only for people in a hospital setting, and some of this there's a bit of truth to this because most palliative care teams are actually based within a hospital. Palliative care is not yet as widely available as I think we would like it to be, particularly for outpatient settings, which are really more limited to large academic centers or cancer centers. And we certainly know that the provision of palliative care in rural areas is much worse than we wish it could be. And then the last one gets to the idea of language, this idea that somehow we're choosing between palliative care and aggressive care. And what I would hope everyone imparts today is that palliative care is an aggressive form of therapy aimed at improving patients' quality of life. The other piece that I think is important to highlight is that there's a tremendous opportunity, and one of the reasons why we're talking today is that we can all be educators in our communities about what palliative care is and is not. So this was a survey done a couple of years ago now by a marketing firm hired by the Center to Advance Palliative Care. And really this organization is, it's actually the conference I'm at right now and speaking to you all from. This organization is aimed at improving the awareness of palliative care as well as the ability, the access for all patients to have access to high quality palliative care. And one of the things they noticed was that there were definitions of palliative care that were out there in the community that made it hard for patients perhaps to want to be involved in palliative care, or maybe it was more that there were physicians who weren't sure what palliative care was and didn't want to refer their patients. And so they commissioned a study across the country of over 1,000 adults looking at across all different walks of life about their knowledge about palliative care. And as you can see by the graph here, the vast majority of people in this country have no knowledge at all about palliative care. What they found is when they gave some good definitions that most people found that this was really important care to have. So here's the definition that I want to share with you because I think this is the definition that really gets at the important part of what palliative care does and does not do. So I'll label it that palliative care is specialized medical care for people with serious illnesses. That the goal is to focus on providing relief from the symptoms, pain, and stress of a serious illness. And the goal is to improve quality of life for both patients and their caregivers, however they're defined. We know that palliative care is not a separate form of care, but an extra layer of support for all patients with a serious illness. And that palliative care is really provided in teams, that this is an interdisciplinary team sport, that we all work together with a patient's primary physician or other clinicians to provide that extra layer of support for patients with a serious illness, and that this care can and should be provided with any patients with a serious illness, even if they're receiving curative intent treatment. When we think about this definition and we ask and survey patients and families about what they want, over 90% of people think that it's important to be educated about palliative care, to make sure that palliative care is available for themselves or a loved one if they had a serious illness, and it should be available at local healthcare facilities so for patients and their family members. I wanted to show a couple of old graphs that have been around for a long time that get at this point. And I'll use the mouse cursor, hopefully people can see this, with the idea that a previous definition of palliative care was that you had two different forms of care. You had aggressive, right, that language again, life-prolonging care. That continued up until the day that the doctor said, there's nothing more we can do, it's time to go to hospice and die. This is a really abrupt transition for many patients, and older surveys of patients, when this was the predominant model of care, patients often felt very abandoned and unsure and surprised about what was happening. And what we're seeing now is that there's a tremendous movement across many medical specialties as well as patient groups and insurers that palliative care needs to be integrated very early on in the diagnosis of a patient with a serious illness like pulmonary hypertension, advanced chronic obstructive pulmonary disease, advanced heart disease, and metastatic cancer. And that palliative care services should either increase or decrease depending on the patient's condition, but likely they're going to increase as a patient progresses through their serious illness towards the end of life. I think the real question for all of us is that what does palliative care back here look like very early on compared to palliative care closer towards the end of life? The reason why I think this question is critical is that most of my patients actually are not patients who are at the end of life. That's actually the minority of our practice now at Mayo Clinic because we're seeing patients so much earlier. And it gets to this overall idea of palliative care being a very wide, encompassing umbrella of which hospice care is a small part. Now, hospice can be a very important form of care and an important insurance benefit for patients with a serious illness and a limited prognosis, who either have no other treatments that can be directed against their disease or for whom the treatments are actually causing worsening quality of life. And that hospice care is a form of palliative care provided towards those patients and comes with insurance benefits provided by Medicare and other forms of private insurance. But palliative care as an overarching form of care serves patients at all stages of a serious illness when quality of life is important. The reason I jumped too early. The reason I focus on the idea of early integration and what that looks like when it's early on in the course of an illness is that when we do this, we actually provide significant benefits to patients and families. Most of the data about early integration of palliative care comes from patients with advanced cancer. However, there have been a number of studies in other disease states, including patients with advanced lung disease, advanced heart disease, advanced kidney disease, and patients in the intensive care unit for other reasons, that getting palliative care involved early can improve patients' mood, their overall quality of life, improve satisfaction with the care that they're receiving, can decrease the physical symptom severity that they're experiencing, can decrease their overall length of stay in a hospital, may prevent chemotherapy at the very end of life where it may not be helpful. And there have been some studies even suggesting that palliative care provided early on can actually improve someone's survival. Let's see, I'm not able to click to the next slide. We'll try it one more time here. There we go. So when you think about palliative care integration starting early, that looks a little bit different than what it might look like in a previous model where palliative care was only at the end of life. And I think it's important to have this early integration because patients and families want access when we talk to them about this. They want access to aggressive disease-modifying treatments and aggressive palliative care working together for the best care of that individualized patient and family. The other thing that we know is that clinical predictions of, for example, patients before an operation are really challenging and often unreliable. That's why even before difficult surgeries, it's important to have palliative care involved because we cannot predict the future. Palliative care can be provided while patients are receiving intensive care, and it doesn't reduce hope, doesn't lead to giving up, and doesn't make patients stop early and die earlier than they would have if they didn't have palliative care. When we think about what early palliative care actually means, I think it's really critical to define what a palliative care team looks like. And I'll show some slides as we move forward, but it's important to talk about the team-based approach to care, that this isn't one physician or one nurse, that this is a physician, nurses, social workers, chaplains, nurse practitioners, or physician assistants, all working together to provide care for a patient, what they need, and meeting them where they are in the course of their illness. When we think about what that care looks like very early on, the care is focused on developing long-term relationships with patients and their family members, not just with one person, but with the whole team. That early relationship allows teams to have time to talk about difficult topics, to provide adaptive coping techniques, because as patients are diagnosed with serious illness, there's a whole host of anxieties and worries that often come with those diagnoses. And so being able to provide some ways to cope with that is an incredibly important part of what early palliative care looks like. Importantly, what we're all going for is to improve quality of life throughout the patient's illness, and that care is highly collaborative with the referring team. Palliative care is not taking over anyone's care, but providing that extra layer of support for the team that's already in charge. So what this might look like, and this is a pretty common example of what a case might look like, whether that was Joe, the patient I talked about earlier, or patients who come into our office with a new diagnosis of cancer, or a patient we're meeting in the intensive care unit after a new diagnosis of a blood clot in the setting of their pulmonary hypertension, or in the coronary care unit when they're having advanced heart failure symptoms. The things that we do with the whole team is to really aggressively manage symptoms. Is there pain? Is there shortness of breath? Is there difficulty sleeping? Is there anxiety that we can aggressively manage? As well as helping patients and their family or caregivers understand their prognosis. And I want to be very careful to talk about what I mean by prognosis. I don't mean necessarily how long someone has to live, but what their life might look like as their disease moves forward. Again, that can be very stressful, and so it's important that we do this by promoting adaptive coping strategies that give patients tools to deal with the difficult and stress of a serious illness. The other things that we often do are talk with patients and families about their goals, their preferences, their worries as they think about their care going forward, and how that can be part of any medical decision making. I hear from patients all the time that they get inundated with information. They can only remember half of it, and people are coming through so often they're not sure which team is actually in the room at each time. It's pretty normal, actually, in a busy hospital setting. And so one way that palliative care can help is to help funnel all that information into some chunks that are easily digestible, and to help patients and families then communicate that to everyone. The other piece that, again, I have to keep emphasizing because it's so important is that it's collaborative with the referring team so that we're all working together to deliver treatment that's consistent with someone's goals, preferences, and values. I think what I want to spend a few minutes on is talking about this struggle about prognosis. And again, I want to mention that, again, prognosis isn't necessarily how long someone might have to live, but it's how that living is going to look like with a serious illness. And we know that patients and their caregivers are often back and forth between hopes that may be more likely to be realized and hope that is sometimes less likely to be realized. It's tough to talk about realism because what's real to one person might be less real to another, especially when they're having lots of information thrown at them. But what I do hear sometimes from other physicians is that, this patient really doesn't understand how bad it is. And oftentimes when I'm talking with that patient, they understand how bad it is, but what they're really struggling with is how to maintain a positive attitude. And I think that's something to touch on for a minute because it's really important that when we think about what coping means, having a positive attitude and being hopeful is a very normal and can be a very healthy coping mechanism for someone with a serious illness. And from a palliative care perspective, what we want to do is try to help patients understand those more realistic and less realistic hopes, but also to think about hope no matter what's happening. Even if bad things are happening, there's always something that we may be able to hope for moving forward. This is really tricky, and it's one of the reasons why palliative care is often involved in really difficult conversations, because this is hard to do for lots of members of the medical team. One of the things that we hear frequently is that we're worried about making patients depressed by giving them honest information, that we don't want to destroy someone's hope by talking about things that are hard to talk about. And I think what's helpful to often remind physicians and sometimes to remind patients and caregivers is that most patients want to know about what their prognosis looks like. Again, what life is likely to be like ahead. And for some patients, they want to know what time is likely to be. Not necessarily the day, because none of us can predict that, but really helping them plan for the future becomes an important exercise for them to help reduce anxiety and to support their family. And I think what's critical is that sicker patients often want more information about what's likely to be ahead so that they can make some of those difficult decisions. It doesn't mean they stop hoping, but it does mean that they also make plans where things don't go as well as they hope. Another piece that's critical is that when we're talking about this, caregivers can suffer. And I put up some numbers here from some surveys of patients and families, which is very consistent across the years, that most patients and particularly their family members and caregivers report that they don't get enough contact or communication with physicians. There's not enough time that's being spent on emotional support or even about what a dying process might look like, whether it's now or in the future. And families and caregivers are worried that their loved ones aren't getting appropriate symptom control, and they don't want to watch them suffer. I think what's important is that early palliative care can improve caregivers' health in a very direct sense. We haven't quite figured out why, but what we know is that when palliative care is involved early on in the course of an illness, caregivers of patients receiving palliative care actually reported fewer depressive symptoms and less anxiety. And this has been true in both patients with advanced cancers, but also patients undergoing potentially curative forms of bone marrow transplant. And we're starting to see it in other disease states as well. So what does this mean, and how do we move forward? I think it's important to talk about how patients can actually access palliative care or supportive care. We put up some different names here because one of the things that you might see is that you'll see different names. It might be a palliative care clinic. It might be a palliative and supportive care clinic. It might be a supportive clinic. Our outpatient palliative care practice is called the Symptom Management, Pain, and Quality of Life Clinic. You'll notice that there's really no palliative care in that name at all. And sometimes this is done because of historical reasons that I think teams are worried that palliative care gives a connotation to physicians that they may not want to send their patients there. But I think it's important to know that the goals, generally speaking, are all the same, that we're here to improve quality of life for patients and family members. It becomes really important to know if the clinic or healthcare system or hospital where you're receiving care provides palliative care services. What I would argue is that if a hospital system or a hospital is taking care of really sick patients, then they have an obligation to have high-quality palliative care available. Now, that's easy for me to say, but it's certainly something if I could wave my magic wand, we would make happen. We do know that this is starting to change, and this is actually starting to happen. About 80% of hospitals with more than 350 beds have a palliative care service, and we're starting to see even smaller hospitals, about half of them, maybe a third to half of them, with more than 100 beds are having some palliative care team clinicians. However, as I mentioned earlier, most palliative care services are based in a hospital system. And that's something where outpatient palliative care practices, where a lot of patients receive care, are still things that we need to advocate for within big health systems who are treating sick patients. And the other thing that I think is worth noting is that if there's not an outpatient clinic at the place where you receive health care, there might be community programs that offer a range of services, of which palliative care may be one of them. I see in a lot of areas that there are really umbrella organizations that have home health care, that have homebound palliative care services or home palliative care services, and hospice all under one organization, often with staff with training in all forms of care for patients with a serious illness. And that can be another way to receive palliative care, even if it's not provided at the healthcare system where you receive your care. I think the other thing that's critical is that palliative care is most often provided as a consultative service, which means a physician or patient needs to ask for the referral. Now, I get patients and family members sometimes say, can I just call up and ask for a referral? And I always say that absolutely they can, because we want to make sure we don't deny care to anybody who feels that they could benefit from it. I also, though, ask them to talk to their doctor about it, who's the primary one in charge, because I think we're always better when we're working together for the care of the patient in front of us, as opposed to having different people working to different things and not talking to one another. It's important, though, is that not all physicians might be comfortable with this up front, and so it's important to clarify why you're talking about it. Again, unfortunately, there's just still some people who see palliative care, who haven't learned about palliative care as being, and really see it as the same as end-of-life care or hospice care. And so I tell patients who are wondering, can I just come and see you, or what should I tell my doctor, to talk about that you're hoping for another team that can help support your existing relationship with your primary treating physician, to talk about some more issues about quality of life, about pain, about other symptoms, or to talk about supporting your family. And often, clinicians are very receptive to that. The piece of why this is really important that we continue to push, not just for specialty palliative care services, but really for all of us as clinicians who are working with seriously ill patients to have these skill sets, is that while we have increased services across the country, there are 90 million patients, this is an estimate even a couple of years ago, which has likely gone up since then, who have diagnoses who could benefit from palliative care involvement. And there's simply not enough of us to go around. And so it's critical that everyone who takes care of a patient with a serious illness needs to have better training in how to talk to patients about difficult things, difficult conversations about coping, about pain, about other symptoms that affect their quality of life. And so this is also about advocating on a national level to make sure that physicians have training in these skill sets as they go through medical school and their specialty training programs. The other piece I think is really critical for all patients to do before they go see any physician is to help them with these skill sets, which is really to prepare ahead of time to talk about what's important to you. One of the things that I ask patients to run through again, depending on what we're talking about, but particularly when they're trying to make tough decisions, are to think about things like, if my health worsens, what goals are most important to me? What are my biggest worries about my health, either right now or if I get sicker? What abilities are so important to me that I can't imagine living without them? I had one patient tell me he was actually had worked in a pastry shop for over 20 years, and he said, they're asking me about a feeding tube. I'd rather die with a piece of pastry in my lung than have food through a tube. And it was important to him because he saw eating and the physical act of enjoying something sweet as part of his quality of life. And so having those concrete examples are really important as physicians so we can make good recommendations for our patients. The other thing that's critical is to make sure that family members know what's important to them and what their priorities are so that they can be good advocates for you. A couple of other things that are important to know, that specialty palliative care services are covered by insurance. I get patients sometimes worried that these are not going to be covered. And generally speaking, insurance companies, if they cover consultative services, whether it's a cardiologist or a kidney specialist or a palliative care specialist, those will be covered by insurance. And the other piece that I say is, again, the language about extra layer of support is a critical one to continue to use. I put up a link here, which is the www.getpalliativecare.org, because it's a link to some resources that are specifically designed for patients and families to go through questions that you can think about whether or not palliative care might be helpful, how to talk to your family about it, and some other links to find resources in your area. All right, so we're going to pull this together in the remaining few minutes, and then we'll have time for questions and conversation. So a couple things to be clear about. Palliative care is excellent evidence-based treatment. It's focusing on care of pain and other symptoms throughout a patient's illness at any age or any stage of a disease. And it's care that patients want and should get at the same time as efforts to cure and prolong life. It's also clear that palliative care is not about giving up on a patient. It's not something done in place of curative or life-prolonging care, and it's not the same as hospice care or comfort care. Palliative care benefits patients, it benefits caregivers, and interestingly, it actually benefits referring clinicians. There's been some really interesting studies done in the last several years about how this actually helps prevent burnout in other clinicians who are taking care of sick patients. And so it's something where hopefully in working together, we all do a better job in taking care of ourselves and our patients and caregivers.
We'll start with the first question that has come in. If palliative care isn't offered at my hospital, where do I turn or what do I ask for?
Yeah, that's a really wonderful question. Thank you for bringing that up. I think there's a couple of things. So the first thing to try to find out is whether or not there are clinicians at that hospital or healthcare system that have had training in palliative care. That's one thing to ask about. The other piece is it's not just the physicians, but many social workers, chaplains, nurses have also had advanced training in palliative care and might be another resource. But I also think that there are some potentially community resources that can be used. So the getpalliativecare.org would be one place to check. But what I also do is I have sometimes done this for patients in the office where I'll just turn to good old Google and look at palliative care resources in whatever the area might be. And those are, sometimes they point towards community organizations that aren't necessarily affiliated with a hospital or with a clinic that might provide those resources in your area.
Great, thank you. So you briefly mentioned insurance coverage and palliative care. What about Medicare or Medicare Part B? Does that cover palliative care?
Yeah, great question. So all of the consultative services, when we think about what's covered, where all consultative services are covered, they will also cover palliative care. So it's not that, for example, if you can get coverage to go see a cardiologist, but you can't get coverage to go see a palliative care specialist. And so with our Medicare population, those are all visits that that we see are covered for patients and their family members. I have run into some difficulties with I've had some difficulties with certain forms of insurance covering a certain number of visits, and so that's the one tricky part that I don't know, and does kind of depend. But most insurance plans will cover all or part of palliative care, just like any other hospital service or outpatient services, and it is certainly true of Medicare and Medicaid. The other, to be sure about that ahead of time, is to check with a social worker. In fact, one of the reasons why we in palliative care are really keen to employ social workers is because they can help us navigate the complexities of the insurance markets, and make sure that we're not burdening our patients and families unnecessarily.
Thank you. Our next question is, do I wait for my care team to bring up a palliative care consultation, or should I ask for one?
So at the risk of getting myself in trouble, I would say don't wait. And the reason for that is that it's a question. It should not be viewed. It shouldn't be viewed as a threatening to some clinicians. Although I can tell you about experiences where that's been the worry. Overall, what I look at is a great opportunity for conversation with your care team. So they may very well ask, well, why are you asking? And I think it's good to be clear with some of the language that I mentioned today, that what you're looking for is added assistance or a second opinion about how best to manage my pain or shortness of breath, or I'm really worried about supporting my spouse or children. And I think those are things that are good to ask up front about. You know, when people say it's too early to think about palliative care, my pushback, because I had this happen to me with my grandparents, is that I clarify that I'm not talking about hospice, and I clarify that I'm not talking about end of life care. That I just want to be prepared and have a team who can help add some added expertise and really work together to get the best quality of life that I can get. I find that when patients do talk about that, it often brings up other things that that care team or physician or nurse practitioner might want to go more into, which they should. But I think as long as you have a few key phrases in your back pocket, hopefully it becomes a productive conversation. So I always tell people to ask as opposed to wait, because the other piece is that some people just aren't aware. And that's not because they're bad or anything else. It's just that they may not be aware of the resources that are available, or about why patients are asking. So I think it's good to ask and not wait.
Thank you, Dr. Strand. Next question. Do palliative care clinicians go on rounds with the PH treating doctors for inpatients, or do they visit patients separately if they are in the hospital?
Oh, thank you for bringing that up. That's a great question. The answer is I don't know. And the reason is because I think it varies from place to place. In our practice, we often go on rounds with some of the PH doctors, the PH teams, when they're visiting patients in the hospital. But other times it's too hard to coordinate everyone's schedule, so they might be separate visits. I do like to go on rounds with the PH team because I learn a lot from being in the room with them. I learn a lot about what they're thinking about, what they're discussing with the patient, so it can be incredibly valuable. And I also find it really valuable to visit alone with a patient and their caregivers, so that I can be a safe space to talk about some things that maybe they don't want to bring up in front of their team. And I want to be careful when I say that, because I don't think it's about hiding things from one team versus another. But one of the things that we do see in palliative care is that we don't hold the keys to someone's treatment. We're not in charge of the decision of whether or not to do a new clinical trial or to go forward with a transplant. Really, our job is to help be an advocate and support patients in their quality of life. And so sometimes I hear things that their patients are worried about telling their primary PH doctors, but then I can help navigate those issues with them. So I think the joint visits are really helpful, and I think it's helpful to do visits one-on-one as well.
Awesome, thank you. Next question. If my doctor and nurse are very busy, how do I know if it's okay to call them if something comes to mind that's important to me, or if side effects are really draining me?
Yeah, thank you for that question. Um, this is tough because I think it's a reality that that clinicians are busy. As a clinician who is busy, I would rather hear from patients about something that's going wrong, particularly when it's about their quality of life worsening, than wait 2 weeks when it becomes a crisis. I think so. I grew up in the Midwest, and so a lot of patients that I take care of are from the Midwest, and I think we all have this Midwest guilt, like we're bothering people. I did a lot of training out in Boston, and I learned a lot from my patients who I worked out in Boston who were not shy about telling me what was going on and what I needed to do about it. And some of it I think is good for patients to have, that you shouldn't worry alone. I think I think it's also good to have a conversation up front with the physician or the nurse about what things should I call you with and what things should I, sort of think about for a while or seek out other resources for. But I think it's always better to call and not worry alone than to self-diagnose and be concerned that somehow they're going to be too busy to take your call. So I think it's a good rule of thumb to go ahead and call if you're worried about something.
Our next question, if palliative care focuses on my quality of life, then it actually could help me live longer, right? That makes me think about that I should know that I should be talking to my doc about it.
Yeah, thank you for bringing that up. So I think that's what we all think, and that's what a lot of the research would support, is that patients who have better quality of life, who have better function, for example, actually end up doing better and living longer. We also know that patients who have less symptoms of depression and anxiety end up physically doing better, but also in many serious illnesses living longer. What's tricky is it's hard to know if one thing causes another, which causes another, what was the exact reason. But I can tell you from my own personal experience, if I had a loved one with a serious illness, I would insist that they have palliative care, because I firmly believe that improved quality of life leads to patients who could potentially live longer than if you're always feeling terrible and in and out of the hospital. Now, there are certain things I want to be also clear that palliative care is not a miracle drug. That our job is to walk with patients and continue to treat symptoms, and there will be things that palliative care can't accomplish. But I do think that anyone facing a serious illness, I think as you're describing, wants to bring every resource available where it's available to try to help them live better and live longer.
Perfect. A definition question. What is the difference between prognosis and survival/survivability?
Yeah, thank you for that one. I think prognosis has a lot of definitions. The way that I think about prognosis is that it's what's likely to be coming ahead, and that can mean survivability. That can mean a physician's estimation about how long someone might live, but it's also not just about survivability. It's what the likely course of this illness is going to be for a particular patient. And so it's about how long am I going to be independent? What are my symptoms going to be like as this disease progresses? What am I likely to have to come back to the hospital more frequently as my disease progresses? That's also about prognosis. So it's not just survivability. It's really what will my life look like going forward.
Thank you. So we're on our last question, so I'll just give attendees a last call for questions. If you want to type them in or raise your hand, you can do so as we walk through this last question. Are palliative care nurses also hospice nurses, and are hospice nurses also palliative care nurses? Or are their roles very specific, or does it just depend on the health system?
Yeah, it's a really important question, because I would say it definitely depends on the health system. Some palliative care nurses also work in hospice, but I would say that they're probably more well defined in a hospital. So in a hospital, it is much more likely that the nurses are specific to palliative care as opposed to blending back and forth. In an outpatient practice or a community organization that has home health, palliative care, and hospice, there's very likely to be a blending of roles where there's shared skill sets. So it will depend on the place that you're encountering that. I can give you our example across our Mayo Clinic system with regards to our hospital practices. All of our nurses are full-time within palliative care and don't spend any time with hospice. They work closely with the hospice nurses because there's a lot of collaboration, there's a lot of teaching of one another and sharing skill sets. But I know of other organizations where those roles are definitely shared. So it will depend on where you're located.